and it's a very good program that he's been doing probably a little over a year now at West Plains, Turning Leaf. And so I don't want to steal any of his thunder, so I'll let him speak.
All right. So talk to you a little bit about what's going on, give you a little background. First, some of the things that are happening in our industry, then some research about effectiveness versus effort among specifically behavioral health clinicians, and then how you can actually use regular feedback tools, specifically the Fit Outcomes that we've been piloting here at Turning Leaf, and I'll actually take you in, show you the practicalities of that. We really are in the midst of a shift in our industry, and not just in the behavioral health, but all of healthcare. This shift is moving from an authority-based medicine model to an evidence-based medicine model. We've all heard the phrase evidence-based practices for a long time. Sometimes we wonder what that really is, like it's some mysterious thing up in the sky. But the whole idea is, instead of using authority and experience and kind of your narrowed personal encounter with a certain type of treatment, you're looking at empirical evidence. You're looking at more manualized care, more organized and structured psychotherapy, and looking at what the actual outcomes of those are. That's what causes it to be evidence-based, meaning we actually are seeing people get better. Now, this shift began with the Institute of Medicine's first landmark book, To Err is Human, Building a Safer Family Health System. It was in 2000. And it was furthermore evidenced by nearly a third of the healthcare that was being provided throughout the nation was ineffective and in sometimes harmful. In a 2011 report, the Institute of Medicine was like, a third of what we're doing is not good. It's actually detrimental. The paradigm shift began to create an appeal for an evidence-based medicine philosophy, and it seeks to look at objective data for clinical decision-making. So in our field, we're pretty intuitive kind of people. We kind of move with relationship and the nuance, but they're calling upon us to not just live in that kind of relational zone, but to be able to produce and to make decisions based upon some objective data. And that might seem difficult, but it isn't really as difficult as it may seem. So when they started doing the research, when they were looking at what was going on in our field, they found there was a gap. There was this big gap between what people did and what they thought they were doing and the outcomes of it. Handmaker and Noddig in 2017 says there's a tremendous gap between what medical treatment is known to work and what treatment patients actually get, because some physicians simply are not aware of what the most effective treatments are, or else have their own reasons for not using them. So the big gap was, we know some things that work, but those aren't exactly what's happening. In our field, specifically in behavioral health, we had people recording that we were doing certain types of treatment, DBT treatment, CBT treatment, and that wasn't actually, when you actually check the fidelity of that treatment by looking at videotapes or audio recordings or interview processes, you were discovering that people were saying they were doing, for example, CBT, but they weren't really doing CBT. There's this massive gap between what we think we're doing, what we say we're doing, and actually what's happening in the delivery of the service. Additional research in this field notes that therapists have a tendency to overestimate their effectiveness. Can you imagine that? And misperceive the outcome of their clients. So we tend to be bent toward the positive. We'll overestimate our effectiveness, we'll overestimate the outcome of the clients, and we really tend to discredit the deteriorating clients, so that we factor it out of our kind of analysis or a sense of what's going on. So the gap really calls for us to take an honest kind of more objective look at what we're doing in the psychotherapy and figuring out how we're going to bridge that gap. Well, the health industry, and it's led by the federal government actually, has been strategizing for a decade now on how they were going to bridge this gap And their answer is value-based programs. And value-based programs basically reward healthcare providers with incentive payments for the quality of care. Okay. And so they're measuring objectively outcomes or the quality of care, the effectiveness of our treatment, and they're going to match our payment system based on that. So we'll pay you if you're really doing your job and you're doing it well, so value based. So how is value determined? They determine the value of what you're doing not by your effort, as valiant as it might be. They determine your value by the outcome, and what is happening within the client. Is there a sense of improvement or progression, and is that measurable and knowable, or is it just intuitive? If it's just intuitive, then they're not going to count that. They're going to look for someone else besides you, the provider, being able to say, yes, there is some kind of change happening. So value-based programs, it's here. We've already heard it. We see it. We are being called upon to track things, to mark things. We've talked about it about using the PHQ-9. We've got all of these metric systems that are kind of being delivered to us, whether it's KPI or BWI. I always call it BMW for some reason, but I love it, BMI. All right, so what are some of the factors that create good outcomes? There's been several pieces of research that kind of said here are 5 factors, and this is what has been condensed to these 5 things. Number 1, a strong therapeutic rapport between patient and therapist. We've known this, we learned this when we were in school, how relationship is the most important thing. In fact, relationship is more important than the actual modality. It is the number 1 thing. Number 2, a therapeutic, trustful, and safe space for therapy to take place in. This is marked significant in the research. This is just challenge for us. How do you create this trustful, therapeutic, safe space remotely? And that's going to factor into probably how we actually continue with remote services after the pandemic crisis subsides. Number 3, an explanation for the presenting disorder or symptomology must be psychologically and culturally relevant and present. So we have to be able to give an explanation to what's happening in the client and how the symptoms connect to it, and it needs to be culturally relevant and present. And the best way I probably can illustrate that is, when somebody walks in and we says, well, the problem is your relationship with your mother. If we don't connect the dots for that, we may be right. There's a primary core relationship of attachment, but if that's not culturally or present, relatively present to the client, then it diminishes the outcome. So it's our ability not just to think strategically or theoretically about what might be happening in a client's symptomology, but that we can actually match it to what they can see in their present experience. So it makes us be very, very client, our language being client-centered rather it being therapist-centered. Number 4, the explanation for the distress provides options for patients to alleviate the distress, and the options must be believed and put into action by the patient. So outcomes are improved when there's an immediate relief or a soon to be experienced alleviation of some measure of distress. You look at some modalities like psychodynamic theory, you're going to be in treatment for, 3 years, and you won't be able to experience some kind of distress relief until year 2 or year 3. When that's the case, outcomes dropped dramatically. In fact, many people dropped out of treatment. So part of our treatment planning and our strategizing to have good outcomes is that we are responding to some of the immediate need that they're feeling and some immediate distress. So a good illustration is if I'm dealing with someone that has a trauma issue, and I know that the root of what their symptoms right now, their anxiety, their flashbacks, their sleeplessness, all this really is rooted in their trauma, and I want to get to that. I'm going to have to do some preliminary work that reduces some symptomology, reduces some distress. If I can reduce some distress, maybe with some mindfulness activities, a couple of, a couple short sessions that focus on these subsidiary or these outer issues. Then they buy into it and they give me the time for the deeper treatment. So you're, instead of going right for the root of something, you have to come from the outside in. When we come from the outside in, outcomes overall tend to go up. All right. So again, we're being not just client-centered, meaning strength-based, but we're becoming aware of what of the symptomology they want to reduce first. Okay. Number 5 is the set of procedures or rituals that the patient and the therapist do that leads the patient in a positive and therapeutic way. So this was, to me, one of the most fascinating pieces of the key things for positive outcomes is rituals. I kind of like rituals because it's kind of my mindset from my faith system, but it's the fact that they're doing the same thing over and over again. They like these kind of anchors in therapy. And when they come into your therapy session and they know kind of that there is a stream, there's a progression from the beginning to the end, and this is what it will look like, outcomes tend to improve. So one of the ways I've adapted number 5, for example, is we start exactly the same way every time, and I end exactly the same way every time. I trigger or announce the conclusion of a session the same way. So we move into that summary phase at the same thing where I'm saying, okay, now let's look back. I say, this is what I say, let's look back, and I'd like for you to think of something that was easy to work through in the session today and something that was difficult to work in the session. That's an immediate trigger. It's time to wrap up. And they begin to summarize, they begin to reflect backwards, and then the last thing is, okay, what was something that you're going to take home today that was good from this session? And then we do the exit interview for fit. So these kind of rituals or patterns go a long way in improving your outcomes as well. When you look at the rest of the data, generally 75% of outpatients record positive improvements in their symptoms within 5 sessions of psychotherapy. 5 to 10% record actually a deterioration, and 15 to 20 indicate they haven't experienced any change at all. That's pretty significant. 25 to 30% of our people going through 5 sessions of therapy and not having any kind of change or having a negative change. So we really want to kind of understand what kind of things make the difference and be able to figure out how we're going to implement them and then how we're going to track them. All right. You can see in this diagram, there's 4 things that showed up. And of the 4 things, there really are only 2 that you have control of as a therapist. The things that may change. So they took the 75% of people that experienced change and said, what is it that made the change? 30%, it was the therapeutic relationship. All right. But even greater than that was variables that were outside of therapy. 40% of the positive change had nothing to do with what was happening in the therapy room. It's what was happening outside. Now, I would argue that what you did in your therapy room may have made it easier for them to actually turn external things positive, but nonetheless, that you had no control over that. You do have control over the therapeutic relationship. You have control over the 15% technique and model factors. Did you use an evidence-based practice, in other words? And then there's this general 15% placebo effect. Someone just goes in therapy, it doesn't matter how good or how bad, they tend to get a little bit better if they have a change of mindset. They're looking for change. And when people go into therapy looking for change, they tend to create some of that own change on their own. So we want to go and begin to pick from this data about good positive outcomes. And we want to say, well, what do we track? All right. And so we can see from here that we're definitely going to track therapeutic relationships. And you're going to see in the tracking model that we use, that's the one of the 2 things that we track. We're only tracking 2 things, and one of them is the therapeutic relationship. So an informed, feedback-informed treatment was kind of designed by Scott Miller. He was part of this original group of research researchers that came up with the information I just shared with you. And he says basically, if you will track two key things, the therapeutic relationship and the symptomology of the client, and continually get feedback from them regarding these two things, then you're going to see improved outcomes and you'll be able to track that outcome progress. So he created what is an ORS and an SRS, okay? The ORS has to do with how they're feeling, the general outcome of the therapeutic experience. Are they getting better? Do they feel like they're getting better? And he selected 4 areas that you measure improvement. And in this solid dark line, you can see in this sample graph, someone being measured. They started off scoring down at a 15, and as they moved through sessions, you saw the increase to where they ended up a little over 30. The other thing they tracked is the therapeutic relationship, and that's in the gray bar you can see up above. All right, they do a 4-question sliding scale at the end of the session, the SRS, and they are rating 4 elements of the relationship for that session. And you can see that this person in this sample started off at just under 35 and ended up at 40, which is the highest you can possibly score. So there's a correlation. You're going to see the correlation as I show you a couple other graphs. As their therapeutic relationship is established and they like what's going on in therapy, the alliance, then you're going to also often see improvement in their symptoms. And I probably should clarify, this gray line here isn't just the relationship, it's the alliance. That's a better way to say it. Because one of the questions is, did you talk about what you wanted to talk about? And that really isn't about the relationship you have with your therapist. You might love them, but never get to talk about what you want to talk about. So alliance is a better way to be thinking about that. All right. So this collaboration between the therapist and client and what the patient reports as outcomes are the core critical elements that we're going to use in feedback-informed treatment. So let me show you some of the websites. First of all, this is Scott Miller up here. He's kind of a funny guy, has lots of humor. Be careful, you click on some of it. He puts music in his website, which I hate, because all of a sudden it starts playing. But nonetheless, you can go to Scott Miller, scottdmiller.com, and he tells you all about FIT. And he's the one that basically designed this particular tracking methodology. He writes a lot about it. He was part of the original team. He doesn't have his own software, but he markets for people some of the brands software. We're using a software that tracks this. That's actually out of New Zealand, I believe, that I'm going to be showing you. However, you can get a license for some of the data and that go along with it. So there's lots of stuff you can find out about this and how do you know whether or not therapy is really working. So we use the measures. When we first started using the measures, we used them on pieces of paper. We handed the client a piece of paper that they scored these 4 things as they started the session, and at the end of the session, we handed them another piece of paper and they scored 4 things again. And then we took that and we entered it into an Excel sheet. Then Noble was gracious to allow us to purchase software so we don't have to do all that paperwork. And so now we hand them either a tablet, we can do it on their phone, so I could actually pull it up on my phone and hand my phone to them, or they can use a computer. We can turn the computer around and they can enter in the 4 scales at the beginning and then the 4 scales at the end. So I'm going to show you www.fit-outcomes.com. Okay, all your clients get entered into this. It's HIPAA compliant. That doesn't mean that you're entering their names. We enter them into Avatar, we enter them into Seymour, we enter them into Fit, we enter them into the FCC app. We do a lot of entering. Okay. Then you can, with Fit-Outcomes, you can actually put tags on them, so you could group them together and look at. So I can look at everybody in the 37th District Drug Court, everyone in the 44th. I can look at everybody that's in intensive outpatient or outpatient, or I can look at just residentials. So you have the ability to kind of look at the data and sort it in different ways. So here's an example of what would happen. So I'm going to show you how a client would actually come in to your office in a session and then mark it. So this is a client up here, and you can see she's already been to 1, 2, 3, 4, 5 sessions. She started off here. She got better, then she had some bad times, and she's back improving. She's loved her therapist and felt like they were in a perfect alignment the entire time. In this particular chart, you see the red, the yellow, and the green. The red zone, they're constantly aggregating all of this data about improvement in health. And so you start getting reports. You can tell that she started off, she immediately went into the green zone and she maintained the green zone. But you're going to see a couple clients I show you that drop down into the yellow, which means there's a cautionary thing. So when we look at this, we look at in supervision, we look at someone's client list, we can say, wow, you have 2 clients that are in the yellow. What's going on with them? Okay. And the clinician can look at that too. A couple of our clinicians actually, they show them their progress, and the clients like to see their progress. And if they score themselves low the previous week or whatever, it's notified. If someone drops into the red zone, whether it's based on their symptomology, they say, look, I'm not doing very well, they drop in the red zone, or if they have a fight with their clinician and they drop in the red zone, then the supervisor can be automatically notified that, hey, something's going on here. Okay. So I'm going to do show you a sample of the new ORS, which is the outcomes. This is what they fill out at the beginning. All right, so I'm going to click on this, and you can see here the 4 things that they measure. First, personal well-being. How are you doing just on your own? So you would come in and you would scale it somewhere. All right. Interpersonally, how are you doing with family or close relationships? They're about middle. I don't have any friends, so we'll go down lower. Socially, what's going on with work, school, or other types of friendships? Well, I just got fired. Overall, general sense of well-being. Well, even though all this is happening, I'm feeling pretty good. So those are the 4 areas that they measure about their own distress. So we're looking at distress in general well-being, distress at work and school and friends, distress in family, and distress individually. And they're measuring that. So they just do that as they come in, and if it's on the tablet, then it's saved. The clinician doesn't even see that. Okay. Well, you can see that based on the scores that I fictitiously did here, it immediately dropped progress down into the yellow zone. All right. When they're done with the session, they're given back the tablet and they fill out the SRS. And this measures relationship with the clinician, goals and topics, approach or method, and then overall feeling. And you can see on the side here, I did not feel heard, understood, and respected versus I felt heard, understood, and respected. So even though things are going bad, we're going to say, look, there's the real strong kind of a relationship. Goals and topics. We did not work on or talk about what I wanted to work on or talk about versus we did. Well, we did. I came in and we actually talked about the things we needed to talk about. The approach is not good fit for me. How well is that client feeling right now about how well they fit in the modality and the personality with the clinician? Then overall, there was something missing in the session today, or overall today's session went well. Right? So they're just scoring it like that. And then you can see it shows up on the graph. All right. So I did not do as well as the previous therapist, I guess. So anyway, you can see then that the SRS is flagged with a red exclamation point. That means there was a significant decline. The reason it was red is because this dashed line here, we can expect clients to move in and out of this, above this dashed line in the green, without having any measurable impact on their outcomes. However, if you begin to drop below this line, In your therapeutic alliance, we start to see decline in outcomes, and then consequently further and further. So here's the actual client over a period of time, okay? A number of sessions. And again, the black line is how they felt, their distress level in those 4 areas. The gray line is the therapeutic alliance. What do you notice about this when you just look at it, when you just look at the graph? You can see that there's kind of a correlation, isn't there, between the therapeutic alliance and how the distress level is. All right, and you can see clearly what was going on, and how things were. He made some progress initially, then there was a great decline, and in that same time didn't feel very connected to his therapist. But as that improved, so did his outcomes. All right, and they continued to get better until he's hit another slump now. And you're able to kind of look at what's happening. Now, what they have discovered in all of this is that there's a 6 to 8 session cycle. People do well, make progress for 8 cycles, and almost always decline after 8, and then they start making progress again and decline after 8. So this is a natural kind of 8 cycle session to how someone improves. All right, so here's a look at a clinician's set of clients here, okay? And so you can see the client name. This one's had 2 sessions, and they're both in the green both times. All right, here you see another client, 4 sessions. The last one was in April, and the last one ended off, he wasn't too happy with his therapist. That may be significant that might impact why he did not return. Over here, you can see this client has had 2 sessions, and she was not doing well, even though she liked what was going on. So you can kind of go through here pretty easily. You can sort these pretty easy, like the latest ones, okay? You can't get a average score until you've had more than 2 sessions. So if first sessions always show up with these question marks. If a clinician forgets to fill out either one of them, then it comes up with an X. But you can see right off the bat what's going on with this client. They dropped in the yellow. We can click on it and make sure we do the most recent one and go to 2 sessions, and we can kind of see what's happening here. Things are really erratic at the beginning. There's not a sense of stability yet. It really helps lead conversations in staffings and in supervisions about, hey, what's happening with your client? I was going to show you another one that I'll just show you one that I think is doing well. Okay, here you can see a consistent alliance with their therapist and a movement upward, 1, 2, 3, 4, 5, 6. Notice on session 7, there's a little bit of a decline, not uncommon. I would expect to start seeing this move up again. Typically, this means that they've either gotten to the end of a kind of a growth cycle and they're taking a break, or it means that they've broken into a new issue and it's starting to cause some distress for them. The last thing I want to show you is that you can look at your agency as a whole or your site as a whole and kind of see a couple of things, average number of sessions, and you can see a change. So I want to say here, you can see that the average intake is 37.52. That's how they felt about their clinician. So our clinicians are making a pretty strong, good first impression, which is really nice. 77% of active clients, 87% of our inactive clients have actually moved from the red or yellow zone into the green zone. So we've had a 77% of our clients have experienced improvement. 87 if you take everybody all together. That's a pretty strong number, okay? And I'm looking at the whole, everybody collected. Let's say I want to go to a specific therapist. Let's go to Missy Leedy, for example. She does our co-occurring here, and you'll see that overall she has an 88.9% improvement rating. And that improvement rating is a raw change score of average of 8.25, or about 8. So when there's an average change of 8 points in their improvement of how they understand the distress of their treatment, with nearly 90% of them moving out of the yellow or red zone and into the green zone. So there's a massive amount of improvement. Here's how you can see if your therapist is actually effective in the room. By looking at the feedback that they're getting from the person who's receiving that service. So that is how it works. We use it in our staffing, we use it in our supervision, we use it to alert ourselves with the condition of clients. And we're hoping that one day, if I could dream for just a second, of this actually being integrated into Avatar and our app. So that this kind of stuff is available. You would be able then to say, hey, here's the value that we're offering. You know, here's the kinds of outcomes that we're seeing in improvement. So if you can do that and continue to invest in evidence-based practices that relieve distress initially, as well as deal with core issues, then I think you're going to navigate the transition and come out at the top, both being able to fund your work and being able to change lives. So, are there any questions that you would like me to answer regarding this?
So I just want to chime in real quick. We're all friends here, so if you don't understand something or you don't understand like why this is important or what's the purpose, just say so, ask. I mean, you know, let us know, because what we're looking at and what I've talked to Dr. Tombley about is, you know, this has been going on over at Turning Leaf for about a year now, and with like he talked about, with things moving towards value-based care, we continue to hear every day about evidence-based practice. This is something that we